This lecture covers part 1 of chronic musculoskeletal conditions. The first chronic musculoskeletal condition that we're going to look at is osteoporosis. The body constantly absorbs and replaces bone tissue. This process is carried out by osteoblasts, which deposit bone, and osteoclasts, which resorb bone. Individuals reach their peak bone mass around age 20 to 25. This can be determined to vary by heredity, nutrition, exercise, and individual hormone function. After about age 35 to 40, bone loss becomes inevitable, although that rate of loss is variable from one individual to the next. With osteoporosis, new bone creation can't keep up with old bone removal, and therefore bone reabsorption begins to exceed bone deposition, leading to the development of the osteoporosis. This condition occurs most commonly in the spine, the hips, and the wrist. And the most common complications that we see with osteoporosis are spontaneous fractures, which is one of the most common symptoms. Many people have no symptoms until they have a bone fracture. 1 in 2 women and 1 in 4 men over age 50 will at some point sustain an osteoporosis-related fracture. This tends to be more common in women because there is a tendency to have a lower calcium intake and they have less bone mass. Also in women, bone reabsorption begins earlier and accelerates faster after menopause and is also affected by breastfeeding and pregnancy. Another common issue related to osteoporosis is a gradual loss of height. Starting at about age 40, people typically lose about 1/2 an inch each decade. Fractures of the bones of the spine are the most common contributing reason for this. It can lead to kyphosis, which is when the back becomes hunched over. This usually isn't too severe of a problem unless it becomes so abnormally curved that it can affect breathing and cause neck and back pain. Treatment and prevention for osteoporosis consists of medications such as bone reabsorption inhibitors, a healthy diet containing adequate amounts of fluoride, calcium, and vitamin D, and getting regular weight-bearing exercise, which helps to prevent the bone loss and strengthen the already weak bones. There are several risk factors for osteoporosis, most commonly being an advancing age, 65 years of age or older. The female gender has a higher risk for developing osteoporosis than men. A low body weight, being a cigarette smoker, having a sedentary lifestyle, women who are postmenopausal are also going to be at higher risk, having a family history, and having poor dietary intake in calcium and vitamin D. Some additional risk factors with osteoporosis consist of someone who consumes excessive alcohol, greater than 2 drinks per day on a regular basis. Caucasian and Asian ethnicities have a higher risk factor for developing osteoporosis as well. In men, one specific risk factor is if there is low testosterone production as well. In regards to diagnostic testing, the most common testing that is done to detect osteoporosis is the bone mineral density testing. The quantitative ultrasound and the dual energy X-ray absorptiometry, or the DEXA scan, are the 2 most commonly performed procedures in diagnosis of osteoporosis. Preferably, screenings begin in women before age 65 and can be repeated every 15 years if they're normal. They need to be repeated earlier and more frequently if the patient is high risk. In men, screening is recommended to begin before age 70 and by age 50 if they are high risk. The dual energy X-ray absorptiometry, or the DEXA scan, is the preferred method of testing and diagnosing osteoporosis. This is considered what we call the gold standard for the diagnosis of osteoporosis. Osteoporosis is diagnosed when the bone mineral density is less than or equal 2.5 standard deviations below that of a young adult reference population, and this is translated as a T-score. T-scores of a -1 or greater is considered normal. T-scores between -2.5 and -1 are considered to be osteopenia, or otherwise known as low bone mass. A T-score of a -2.5 or below is consistent with osteoporosis. For example, a T-score of a -3 or -3.5 would also fall in the osteoporosis category, whereas a T-score of -0.5 or +1 or +2 would classify as normal bone density. The Z-score, which is also usually determined with the DEXA scan, is a comparison of the patient's bone density with someone their own age and ethnicity. The T-score is a comparison of that patient's bone density against a 30-year-old's bone density. Other diagnostics involved in the detection of osteoporosis could be X-rays. Although these are primarily done just to detect fractures, they generally don't show density changes until about 50% of the bone is lost. Treatment for osteoporosis begins if a T-score is found to be less than -2.5. If the T-score is between -1 and -2.5 and the patient has additional risk factors, they will also be considered appropriate for treatment, or anyone who has had a prior history of a hip or a vertebral fracture. Treatment consists of making sure that the patient has adequate calcium intake. 1,000 milligrams per day is recommended for both pre- and postmenopausal women who are taking estrogen. 1,500 milligrams per day is recommended for postmenopausal women who are not taking estrogen. And supplemental calcium can also be given in divided doses with food to enhance its absorption. Some good sources of calcium in their diet could include recommending milk, yogurt, turnip greens, cottage cheese, ice cream, sardines, and spinach. All of these are great examples of increasing the calcium intake. In addition to calcium intake, vitamin D intake is also necessary for calcium absorption and function and for bone formation. Vitamin D can be obtained through at least 20 minutes a day of adequate sunlight and through supplements. Vitamin D supplement administration is recommended for individuals who are postmenopausal, who are over age 65, if they're homebound, or if they have minimal sun exposure. Another recommendation for the treatment of osteoporosis are the weight-bearing exercises. This helps to build up and maintain adequate bone mass. It increases the patient's strength, their coordination, and balance. Weight-bearing exercises could include things such as taking a daily walk, a hike, doing some weight training, stair climbing, tennis or dancing, any of those things, as long as it's not contraindicated by their physician for other reasons. Additional recommendations would include to stop smoking and decrease their alcohol intake, and to treat any other existing disease. In addition to these diet and lifestyle changes that are used for the treatment of osteoporosis, we also have drug therapy. ATI Pharm Made Easy covers several of the different types of medications used in the treatment of osteoporosis, and so you will be reviewing that as part of your required assignments for class. Common medications used are bone reabsorption inhibitors, or otherwise known as bisphosphonates, such as Fosamax, which is the brand name. Alendronate sodium is the generic name for that medication. These medications work to inhibit bone reabsorption. They do have some side effects such as anorexia, weight loss, and gastritis. And it's important to note that bone reabsorption inhibitors do require proper administration, and that can vary from one medication to the next. Some of the most common administration guidelines that come along with our biphosphonates or our bone reabsorption inhibitors are that they usually need to be taken with a full glass of water, and they should be taken 30 minutes before food or any of their other medications so that there is no interference with absorption. And the patient should also remain upright for at least 30 minutes after taking the medication. Another commonly used medication is calcitonin. This also inhibits bone reabsorption. It can be given intranasally, and it also can be given in an IM form. If it is given IM, it usually is recommended to be given at night to minimize the side effects. If it's given intranasally, the patient should be advised that they need to alternate nostrils each day. And it will also be recommended that they take calcium supplementation along with the calcitonin. Another treatment for osteoporosis is the vertebroplasty. This is when bone cement is injected through a small hole in the skin into a fractured vertebrae in order to relieve the pain of the compression fractures that are commonly associated along the vertebrae in relation to osteoporosis. Osteoporosis resulting in compression fractures is just one of the many reasons that we can see individuals with lower back pain. Lower back pain is a condition that affects approximately 80% of all individuals in the United States at least once. It is second only to headaches as the most common complaint of pain. It's responsible for more lost working hours in persons over age 45. Lower back pain is the most common area of the back that pain is recognized because the lumbar region bears the majority of weight, it's the most flexible, and it contains the nerve roots. Lower back pain can be localized or it can be diffuse, and it can be acute or it can be chronic. Acute lower back pain is characterized by lasting 4 weeks or less. It's usually going to be caused by some type of trauma or undue stress. Symptoms with acute lower back pain appear within 24 hours of the injury, and they're going to be anywhere from a muscle ache to a shooting and stabbing pain. It leads to limited flexibility and range of motion in the individual and an inability for them to stand straight up. Chronic back pain, in contrast, lasts longer than 3 months or is characterized by repeated incapacitating episodes. Chronic back pain is often progressive. Most often, lower back pain is due to some type of musculoskeletal problem, such as a lumbosacral strain or instability, the development of osteoarthritis, spinal stenosis, or degenerative disc disease. We're going to talk more closely about spinal stenosis and degenerative disc disease in later slides. There are several risk factors mentioned here for lower back pain, such as a lack of muscle tone or excess body weight. Anybody with poor posture or prior compression fractures are going to be at higher risk for having back pain, and occupational risks as well. Occupational risks are going to include activities such as repetitive lifting, vibration, anybody who experiences prolonged sitting. Healthcare personnel engaged in patient care are going to be at a higher risk for developing lower back pain. Some specific symptoms associated with lower back pain, not just pain in the back, but pain that can radiate into the buttocks and or one leg. Numbness and tingling or weakness down one leg can also be associated with lower back pain and injuries. Interrupted sleep and muscle spasms as well. In regards to diagnostics, one of the simplest diagnostics to do in association with lower back pain is to first determine or get a better idea of the location of the low back pain or where it's originating from. The straight leg raise, which has been mentioned in a previous lecture covering assessment, is one that can give some information regarding more details in just where the back pain is originating from. So with the straight leg raise, if you'll recall, it was positive for something such as a disc herniation when the pain occurs between 30 and 70 degrees angle as the patient raises their leg off of the bed. This particular diagnostic screening does not have to be active range of motion. If the patient's unable to raise their leg, it can be done through passive range of motion as well. Some other tests that could be performed is the myelogram, CT scans, and MRIs to detect the specific type of injury contributing to the back pain. And electromyography is also something that could possibly be done, again, in just aiding in the diagnosis of the cause of the back pain. Generally, back pain, unless it's severe and incapacitating, is going to be treated as an outpatient. It's going to be treated with analgesics, muscle relaxants, possibly massage, acupuncture, and cold and hot compresses. If the patient experiences symptoms consistent with nerve root impairment, then the patient may be a candidate for being hospitalized. We'll talk about that in just a moment. Our overall goals in the care of the patient with the lower back pain obviously is to get them to report satisfactory pain relief, to get them down to at least a 4 or less on a 10-point scale, and for them to be able to, that they've demonstrated a return to their prior level of mobility within their prescribed restrictions. We want them to demonstrate correct performance of their exercises, and we want them to be able to use coping behaviors to effectively adapt to the effects of their acute pain. Patient teaching for prevention is imperative with lower back pain injuries and prevention of future injuries. And so that includes teaching of proper body mechanics. We want to make sure that we teach the patient they should not lean forward without bending their knees. They should never lift anything above the level of their elbows. They should stand in one position, or they should not stand in one position for a prolonged period of time. And we do not recommend they sleep on their abdomen or on their back or their side with their legs out straight. They should exercise only after consulting with a healthcare provider if they're having severe pain. We do recommend, in regards to proper body mechanics, that they prevent their lower back strain by placing a foot on a step or a stool if they do need to stand for a prolonged period of time, that they take efforts to maintain an appropriate body weight. We want them to exercise at least 15 minutes in the morning and the evening on a regular basis, carry light items close to their body, use local heat and cold applications as necessary. They could also use a lumbar roll or a pillow for sitting. And proper sleep positionings would be to sleep in a side-lying position with their knees and hips bent. They could also sleep on their back with a lift under their knees and legs, or on their back with a pillow under their knees to flex their hips and knees. They might need some occupational counseling depending on the job that they do, and we would also recommend that they stop smoking. One specific cause of lower back pain could be spinal stenosis, where there is a narrowing of the spinal canal. This can be either an acquired condition related to something such as osteoarthritis or rheumatoid arthritis, and it could be an inherited condition known as congenital spinal stenosis, or inherited through the condition of scoliosis. What we see with spinal stenosis is that it occurs when the spinal canal, which contains the nerve roots and the spinal cord, becomes compressed. This causes a pinching of the spinal cord and or the nerve roots, and this leads to pain, cramping, weakness, and or numbness in the patient. The symptoms of spinal stenosis often start slowly and they get worse over time. Their pain in their legs can become so severe that even walking a short distance can become unbearable. Frequently, sufferers of spinal stenosis need to sit or lean forward, such as over a grocery cart, a countertop, or a walker, to ease their pain. So as you see here, we have a few symptoms on our list, that the pain is in the lower back and it tends to radiate to the buttock and a leg. It increases when they're walking and even when they're standing without walking, but the pain decreases when they bend forward or sit down, as I just mentioned. They also tend to frequently have the numbness, tingling, weakness, and heaviness in their legs. There are a variety of medications that can be used in the care of spinal stenosis. First off, mild analgesics such as ibuprofen, naproxen, or acetaminophen can be used temporarily to ease the discomfort associated with spinal stenosis. They're typically only recommended for a short time, and there is little evidence that the patient benefits from the long-term use of these mild analgesics. Some other medications that can be taken more long-term are antidepressant therapies, a nightly dose of tricyclic antidepressants. Amitriptyline is one, duloxetine is another antidepressant that might be administered. This is going to be more helpful for chronic pain. And then also some anticonvulsant medications such as gabapentin, pregabalin. These can be used to reduce the pain caused by the damaged nerves. And those also can be taken long term. In addition to medication therapy, exercise and activity throughout the day with sufficient rest periods is also recommended. The regular exercise can help build and maintain strength in the muscles of the arms and the upper legs, and this can help to improve the patient's balance, their ability to walk, their ability to bend and move about, as well as controlling their pain. Some other approaches to the management of pain are going to be the use of heat and cold applications as needed, weight reduction if they are considered to be overweight, other complementary and alternative therapies, and along with, complementary therapies can be done in addition to our traditional medical therapies. Alternative therapies can be things that the patient can choose in lieu of traditional medical care. When these things don't work, minimally invasive treatments such as the epidural corticosteroid injections or the implanted devices to deliver analgesia may be an option. The steroid injections are delivered into the area around the spinal cord. They work to provide temporary and occasionally permanent relief of pain, but most often just some temporary relief of the pain. The injection of the steroid will not fix the impingement. It won't fix the stenosis, but what it can do is help to reduce the inflammation and ultimately relieve some of the pain. In worst case scenarios, when other options for the care of the spinal stenosis pain is not working, the patient may be a candidate for surgery. So in patients with severe or worsening symptoms, they may do what's called a decompression laminectomy. This is a surgery that removes the bony spurs and the buildup of bone in the spinal canal. It helps to free up the space for the nerves in the spinal cord in the spinal canal. After performing the decompression laminectomy, the surgeon often goes ahead and performs a spinal fusion as well to connect two or more vertebrae together to provide better support for the spine. Another common cause for chronic lower back pain could be some type of intervertebral disc disease. It can generally occur at any vertebral level, although it is more common in the cervical and the lumbar areas because they have the greatest flexibility. Intervertebral disc disease can be any one of the following examples. It could be a deterioration of the disc. It could be a bulging of the disc, herniation of the disc, or a thinning of the disc. Discs tend to thin as they dry out. The thinning of the disc oftentimes can lead to a bulging of it, causing it to become compressed and change its normal shape. And a bulging disc oftentimes can lead even then to a herniated disc where the nucleus pulposus actually seeps out. Symptoms associated with disc disease most often is going to be the report of the lower back pain. Patients may also report what is known as radicular pain. Radicular pain is a radiating pain, numbness, and tingling, and decrease of strength and or range of motion that results from a pinched nerve. Another term for this is called radiculopathy. The positive straight leg raise would also be another manifestation of disc disease, possibly decreased or absent reflexes due to nerve impairment, paresthesia as well due to the nerve impairment. One thing to note is if the disc disease is occurring in the cervical area versus the lumbar area, the pain will obviously be higher up. It tends to radiate into the arms and hands rather than the lower extremities, and affects the reflexes of the upper extremities and the hand grips instead of affecting anything in the lower extremities. The last thing I want to talk about here is the quad equina syndrome. This is a rare disorder that is considered a surgical emergency, and it can occur in individuals with disc disease when the spinal nerve roots called the quad equina become suddenly severely compressed. These nerve roots are responsible for sending and receiving messages to and from your legs, feet, and your pelvic organs. So if there is a severe compression suddenly of this nerve root or this bunch of nerve roots, it can cause some debilitating symptoms in the patient. The most common cause for the sudden development of aquata equina syndrome is that a disc in the lumbar area becomes severely ruptured. We can also see it, though, occur in cases of spinal stenosis, as previously discussed. We can see it happen in patients who have spinal lesions or tumors, somebody with a spinal infection or inflammation, or spinal fractures as well. The most common symptoms that quata equina syndrome is developing are going to be a sudden onset of bowel and bladder incontinence, sudden onset of sexual dysfunction. They would be reporting severe lower back pain, and they would have pain, numbness, and weakness in one or both legs that would be so significant they would stumble or have trouble even getting out of a chair. They will likely report to altered sensation in their legs, buttocks, and inner thighs. And this is a feeling that would get worse and worse as the compression continued. This is oftentimes known as saddle anesthesia, and that is consistent with quata equina syndrome. So saddle anesthesia is going to be where they have that pain and numbness and weakness in usually their inner thighs, the back of their legs, and their buttocks. Generally, trouble feeling anything in the areas of the body that would sit on a saddle. Quata equina syndrome is a medical emergency, and the treatment is to perform surgery as quickly as possible. In the most ideal circumstances, surgery would be done within 4 to 8 hours of the onset of symptoms to prevent permanent damage such as paralysis of the legs, permanent loss of bowel or bladder control, sexual function, or other problems. These patients also often need high doses of corticosteroids to reduce the swelling. And even with the treatment and the surgery, it may not retrieve the patient's full functions. It depends on how much damage has occurred, how quickly surgery was done. If the surgery was successful, they can continue to recover bowel and bladder function over a period of months to years. Treatment for the patient with this disease would start off with a conservative approach, limiting their movement, using heat and ice therapy, ultrasound, possibly massage, maybe some skin traction, or even the use of a TENS unit. Drug therapy would oftentimes be incorporated as well. NSAIDs, maybe some short-term opioid treatment for severe pain, some muscle relaxants, the anti-seizure, anticonvulsant drugs, antidepressants, and even those epidural corticosteroid injections that were discussed previously. We would also recommend the patient do some strengthening exercises for their back twice a day. And this isn't just during the recovery period, but it's recommended for a lifetime. We would want to reinforce those good body mechanics that we mentioned earlier, as far as lifting and sleeping and turning and repositioning. We want them to avoid any extremes of flexion. Most of the time, patients can see improvement within 6 months. Their surgery is indicated if the conservative treatments mentioned previously fail, if their radiculopathy worsens, obviously if they exhibit that bowel or bladder control loss that we just mentioned on the previous slide, indicating the likelihood of quata equina syndrome developing. If the patient's having constant pain or persistent neurological deficits, they would also be a candidate for surgery. When spinal surgery is recommended, there are a couple of different approaches that can be taken. The first is the laminectomy, where they will surgically remove the disc through an excision in part of the vertebrae. The discectomy is where they will surgically decompress the nerve root. They can do an artificial disc replacement in conjunction with the discectomy, where they make a small incision after they remove the damaged disc, and they place an implant. And then there's spinal fusion. Spinal fusion is when the spine is stabilized by creating a fusion of contiguous vertebrae. It's done using a bone graft from the patient's fibula or iliac crest. It can also be done with donated cadaver bone. They can also use metal fixation to add stability to the spinal fusion. And they may use a substance known as bone morphogenetic protein to stimulate the bone growth. They can also possibly do a bone graft. Post-op care is important to be familiar with in the patient that's recently had some type of spinal surgery done. One of the most important factors post-operatively is to make sure that you maintain proper alignment of the patient. They may need to be log rolled for a period of time. Their allowed activity is going to vary depending on the type of spinal surgery that they had and depending on the surgeon's preference. Patients who have had a lumbar fusion will need to have pillows placed under their thighs when lying supine, and they'll have to have pillows placed between their legs if they are side lying. They're generally going to come out of surgery on a patient-controlled analgesia or PCA pump, and they'll be switched to oral drugs as soon as they are able to tolerate oral intake. They'll use opioids for about 24 to 48 hours, and they'll also use muscle relaxants. We'll want to get them off the IV administration of opioid therapy and onto the oral administration as quickly as possible in preparation for their discharge. We're going to watch their dressing carefully for the potential of cerebral spinal fluid leakage. We would also monitor them for any reports of a severe headache. Knowing that the cerebral spinal fluid leakage is occurring would require monitoring of the dressing and looking for the appearance of any clear or slightly yellow drainage on the surface of the dressing. This drainage can be tested to see if it's positive for glucose. That is an indication that it is cerebral spinal fluid if it does have a positive glucose finding. We're also going to want to carefully monitor their peripheral neurological signs, which would include assessment for any tingling, numbness, paresthesia of their lower extremities. Additionally, we would want to assess their circulation in their lower extremities, checking them for temp, capillary refill, and the presence of pulses. If a bone graft was used, there will be a second site to assess. That should also be assessed on a regular basis. It can be the iliac crest or the fibula, as mentioned, that would need to be monitored. Oftentimes, patients report the donor site is more painful than the fusion site. They would also need some patient teaching regarding their activity level, proper body mechanics, to avoid prolonged sitting or standing. They should not be doing any lifting or twisting, and they should sleep on a firm mattress or a bed board.